Great. They were very worried they wouldn't get answered the questions, so you'll be first. So thank you very much for the invitation to come and speak today. My remit really was to talk about the ethics and legalities of advanced care planning. But really, this is a conversation for all of us. This is a talk about advanced care planning for everyone. Relevant for patients who have motor neuron disease, but relevant to all of us, really. So over the next 20 minutes or so, this is what we're going to run through. Firstly, we're just going to build on that theme of how good are we at talking about our own mortality. Look at the key components of advanced care planning and the main principles of advanced care planning. Where can patients with motor neuron disease find out more about this? And then we'll look at the ethics of decision making. There's been a lot of talk about that already. We're going to focus on how do we assess someone's capacity. And then some of the legal considerations for Northern Ireland, because we are undergoing a bit of a shift in legality of capacity in advanced care planning here at present. And then I'll look to the future for advanced care planning across Northern Ireland. So you've had your ice cream, so a bit of exercise to work it off, okay? A quick straw poll, so those at the front can turn around and look at the back as well, just to get a feel for the room. Hands up if you've written a will. Not bad. Hands up if you've talked to someone about what treatments you might want or not want at the end of your life. Surprising, okay. Hands up if you talked to somebody about your funeral wishes. These are all the same people. And finally, hands up if you have talked to someone about where you might want to die. Again, not bad. 20, 30 people. So this is a pretty good room in terms of advanced care planning already. I'm impressed. How do we compare? So the National Council for Palliative Care conducted the Dying Matters survey, surveyed around 2,000 adults across Great Britain. 83% were found to feel uncomfortable talking about death and dying. More than half, so just 51% who had a partner, were totally unaware of what their partner's wishes might be for end of life. Only 36% of those surveyed had written a will. 29% had spoken to others about their funeral wishes. Only 6% had actually written down their preferences for future care. A quarter of GPs admitted to never having discussed end-of-life concerns with patients, while 40% of GPs had talked to someone about their own end-of-life wishes. So it really raises the question again, and it's come up a few times. Why do we find it hard to talk about death? Because this is the main stumbling block for advanced care planning. If we cannot talk about death, we cannot plan for end of life. And I think it boils down to this. Talking about end of life is uncomfortable. It is not part of our culture to discuss death and dying. It's not a dinner table conversation. And we all know people who avoid uncomfortable conversations. And we can probably count ourselves among those people. But I think more than being uncomfortable, there are genuine fears surrounding addressing end-of-life issues. And one of that is hope. And we hear this a lot. We hear this a lot from families. Don't tell them what they have, it'll kill them. Hope is a big thing, and hope's important, and we should just think about hope briefly. Hope is something that helps us determine our future goals. So hope's important in beginning to plan for our future. But the difference in the importance of advanced care planning is that it fosters a realistic hope. There's danger in unrealistic hopes and filling people full of false promise. So advanced care planning is really designed to foster realistic hope in people. More information should lead to less fear, should lead to more control. And truth-telling is hugely important in healthcare. Truth-telling to maintain your professional relationships, to preserve normality for people, to reduce any feelings for people being a burden, and encourage patients, we've heard this already today, encourage that sense of control. So, done correctly, advanced care planning should be empowering and can be enabling and can help foster realistic hopes. Not only that, it's a regional priority. So it's one of the big things in the Regional Palliative Care Programme Board for this year and next year, advanced care planning. And this is from the Public Health Agency. Just a brief definition. They say it should be an ongoing process. It should focus on the person's wishes and preferences for their care. And advanced care planning itself is a bit of an umbrella term. It covers the legal, personal and clinical planning to help prepare for someone's future. So we'll just break that down a little bit and look at the main components. So personal and clinical areas. So within personal planning, thinking about practical things like making a will, planning for your funeral, recording a record of your wishes, thinking about things like enduring power of attorney, and we'll go on to talk a little bit more about the legality of that. Clinical things like what support services are going to be needed, where might you want to be looked after, what would be your preferred place of care for end of life. Have you thought about any advanced decisions to refuse treatment? Have you thought about resuscitation? And have you thought about organ donation? So they are all the main components of advanced care planning, and all of them combine to have an advanced care plan summary. So these, I think, were given out today as well. So this is the regional booklet, recently redesigned, and it has a couple of key sheets within it. So it has a record of my wishes. So this is a document for individuals to record what is important to them, what's important in their life, what's important for their future care, where might they want to be looked after, who are the important people that should be involved in discussions surrounding their care. It has a template form as well for advanced decisions to refuse treatment, and it also has a checklist thinking through some of those practical things like, have you made a will, where are all your legal documents kept, where are your bank details kept. So we'll have a quick think about the principles of advanced care planning. Firstly, it should be voluntary. Nobody should be made advanced care plan. So it's something, if people want to engage with it, we should encourage it. It should be done over time and have an opportunity for it to be regularly reviewed. The individual should have sufficient capacity, and I suppose that's the legal term, and we'll talk a little bit about what sufficient capacity is in a short while. It shouldn't be a tick box exercise. So although there is a regional drive for advanced care planning and we should be doing it more and more, you shouldn't be doing it just for the sake of doing it, like hearing about the DNA CPR form being posted out. It could be for everyone. This is a talk that should be for all of us. We should all start thinking about these things, but it becomes particularly important when you have conditions like motor neuron disease, when you have serious progressive life-limiting illness. As we've already said, it can all be recorded in a summary, and that can be shared with important people. And while we should always try and honour what people want in their advanced care plan, it might not always be practically possible, and this is what comes down to provision of carers. Maybe someone's symptoms and needs at the end of life will dictate where they need to be if it isn't going to be their own home. And it might not be for everyone, and that's okay. If people don't want an advanced care plan, we shouldn't be forcing them to. The MND Association website has a whole section on planning ahead for end-of-life care. So patients who have motor neuron disease will get a lot more information on all of that, and Ruth has already talked us through the EDRT forms. So we're going to move on to the ethics, and there's three main questions I want to address when it comes to the ethics of decision making. The first is, how should we go about making reasoned decisions for our patients in healthcare? The second is, why do patients need to be involved in decisions? And finally, to participate in advanced care planning, you need to have sufficient capacity. So what is that, and how do we go about assessing someone's capacity? So we might ask questions now, because you heard this earlier. So decision making in healthcare, we use principlism. So this is the ethical framework for medicine. So it isn't an ethical theory, it's based on deontology, so it's based in duties. So deontology will tell us that there are rights and there are wrongs, and things are always right and things are always wrong. But life, and particularly healthcare, is not black and white, so we can't rely on deontology. So instead we have principlism. And it's based on prima facie rules. So at first sight, all four of these things are incredibly important, and none of them should ever be overwritten, or one is not more important than the other. But in reality, all of them will infringe on each other depending on what course of action we take. So this is as good as we've got for healthcare. Our four big principles, what are they? You heard them earlier. Great, you've got them. In combination, you've got them there. So the first is respect for autonomy, and that's really important to emphasize the first two words here. It isn't autonomy, it's respect for autonomy. We respect our patients' rights to make autonomous decisions about their care. So autonomy is not absolute. Just because somebody wants something doesn't mean that they get it. Non-maleficence, avoiding harm, beneficence, doing good, and any justice issues, making sure that all treatment is equitable for all. So the weighing scales are often used as the analogy for this, that you balance all of these things up, but that's a little bit misleading because one is not more important than the other. Autonomy doesn't override everything else. All four of them have to be taken and applied. So we call this applied medical ethics. You take your four principles, you relate them all to the case, to your patient that you're trying to work out what to do for. And by specifying each of those four principles, you should come to an easy conclusion. Now, if you don't, and this is where the confusion comes from, I think they call it balancing, but really the balance is to try and find whatever course of action has the least infringement of all four principles. But really this is why. This answers your second question. Why should patients be involved in decisions about their care? It's because of our first principle, and first among equals, of respect for autonomy. Patients who have capacity should be fit to make autonomous decisions, and that's really the driving force for healthcare, for patient-centred care. In terms of where we can look for reference, for more guidance, the General Medical Council has two key documents that we're going to just look at some of the key components for both of these now: treatment and care towards end of life and consent. So we'll just tease out the main things in both of these in relation to consent and capacity. GMC say that we must presume capacity for all adult patients. So when you're walking in to meet a patient, the presumption is this person has got capacity, and it is your duty to prove that they don't, if that is what your concern is. We should maximise your capacity, so you shouldn't be waking someone up at 3 o'clock in the morning and shining a light in their eye and asking them questions. It should be done at a reasonable time. It should be done with information that they can understand. They should be surrounded by the people that will help them understand that. You should overcome any communication difficulties. You should maximise their capacity. And importantly, capacity should be made at the time it needs to be decided on. Should someone not have capacity, we've heard this term already today, we make a best interest decision. So if someone doesn't have capacity, currently here in Northern Ireland, the only person that can make a decision for that person is the clinician in charge, not family. But the General Medical Council are very clear that if you're making a best interest decision, you should be consulting those closest to that person. What if there's any disputes? It's always good to seek advice from a more senior colleague. Hold a case conference, get a second opinion. Failing that, seek a legal opinion. So the courts in England, Wales and Northern Ireland will refer to whether something is in the patient's best interest, and courts in Scotland will decide if a treatment is of benefit to the patient. In terms of where we are just with the legislation for capacity, it is slightly different across the UK. So in England and Wales, we have had the Mental Capacity Act, which has driven legislation in common law here, really. Scotland have Adults with Incapacity Act, but in Northern Ireland, we have just relied on that common law. Because Mental Capacity Act applies for capacity in England and Wales, under common law, it is applied to us. And we were making decisions under a best interest choice. The only other thing we did have here was the mental health order. So that allowed us to outline when patients can be treated without consent, but purely for mental health disorders. But last year, the Mental Capacity Act was passed. Hands up, who was aware of that? Okay, about half the room. So Northern Ireland is the first jurisdiction in the world to fuse capacity and mental health legislation. And we're waiting for the implementation of this, and this is going to radically shift the ethics and legality of capacity and healthcare in Northern Ireland. So it became law on the 9th of May last year. In terms of advanced decisions though, and advanced care planning, that remains a live issue in the department. So it isn't covered actually under the legislation, and this is just an excerpt from the Northern Ireland Assembly when they were talking about the final bill coming through. And they said that within 3 years of the Act coming into operation, they should have looked at this again, they should have thought about advanced decisions again. Up until then, it's still going to remain under common law, so these things are going to be covered because it's legislated for in England and Wales. It'll be covered under common law here. But in 3 years' time, advanced decisions, there should be something firmer and hopefully some firmer legislation to guide us in advanced decisions here. So it leaves us still with this scenario of how do you assess capacity? So there's commonly two answers to this. One, phone a psychiatrist. We heard about that earlier. You don't always have to phone psychiatrists, but they're really useful when you do need to phone them. The second, become a psychiatrist. But as we know, we don't need to do that. So the question, how do you assess capacity? So it's all about the functional test. This functional test really comes from the Mental Capacity Act, but it is in the draft code of practice for our own Mental Capacity Act, and it's largely unchanged. There's 4 criteria. First is that the individual must understand and believe what you're telling them. They must understand and believe the condition that you're telling them that they have. They should retain that information long enough to make a decision. That might be a few minutes, it might be a few hours, it might be a few days. It'll depend on the decision they're making. They should weigh up using reasoning. They must demonstrate some form of reasoning to weigh up their decision. And then communicate that. And this is part of what we're talking about, maximizing capacity. If someone has communication issues, you should be maximizing their ability to communicate their wishes. So if you meet those 4 criteria, you have capacity. If you can understand and believe, if you can retain that information long enough to think about it, demonstrate some level of reasoning in making your decision and communicate it, then you've got capacity for that question that you've been asked. Capacity can come and go, and that's another really important point. It isn't a situation of either having capacity or not having capacity. Even if you have a mental impairment, you can still have capacity to make certain decisions. So when you're assessing capacity, it must be at that time for that decision that you're asking the patient to make. And as has been said earlier, patients with capacity can make autonomous decisions that you don't agree with. So as long as they have believed what you've told them, thought about it, demonstrated some reasoning, even if you don't agree with how they've come to their decision and communicated it, that's okay. So I'm going to move on to some of the legal considerations. What is enshrined in law? So there's a lot of discussion about CPR and who can decide about CPR and who can give CPR, and a lot of confusion, I think, surrounding CPR conversations. The decision to give CPR rests with the senior clinician in charge. So CPR is a medical treatment like any other. So all a patient can do is refuse to have that medical treatment. Patients cannot demand to have CPR. If the clinician feels that CPR will be successful, then that is something that will be offered. But if they feel that CPR won't work, then it's deemed a futile treatment, and there is no legal obligation to give a futile treatment. In terms of advanced statements, they're not legally binding, but they should be used when making any best interest decisions, and that comes time and time again in case law. Advanced decisions to refuse treatment are legally binding. So these are recognised currently under common law in Northern Ireland, and we're waiting for this Mental Capacity Act of 2016 to be implemented. So they are legally binding. In terms of just the legalities of ADRTs, and they're known as living wills as well. So they come into effect when an individual has lost that capacity or the ability to communicate their wishes. Up until that point, individuals will be able to tell you what they want or don't want. So these things become useful when that ability has been lost. They can be used to refuse treatments. So if you want to refuse resuscitation, artificial feeding, antibiotics, ventilation, that's what an advanced decision to refuse treatment is for. But it has to meet 2 legal criteria. It must be valid and it must be applicable, and we're going to break that down in a wee minute. They cannot be used to request treatment, especially futile treatments or illegal acts like assisted suicide, and they cannot be used to refuse basic care either. So what is valid and what is applicable? So this is guidance as well from the General Medical Council. So for it to be valid, they've had to be an adult when they made it. They should have had capacity at the time of its completion. They should have been under no undue influence, and they should have been well informed about the decisions they were making. If it's refusing a life-sustaining or potentially life-sustaining treatment, it should be in writing, it should be signed, and it should be witnessed, and it should also include a statement along the lines of my life being at risk, or even if my life is at risk, and we see that in the MND ADRT form as well as the regional ADRT forms. It should be consistent with subsequent decisions, so if this was written years ago, all the patient has done since that should tally with their choices still. So if you meet all of that, then it's valid. Second question you have to ask about your ADRT is it applicable? It must be really clear about the circumstances in which it applies. So it should be unambiguous. It must be specific for the treatment that's being declined and the circumstances that the patient finds himself in. So if it meets that, then it's applicable. Again, preferably in writing, and I put that in because ADRTs do not necessarily have to be in writing. These can be verbal, they can be written down by someone else. The Mental Capacity Act and guidance from the General Medical Council will stipulate that if it's refusing life-sustaining treatment, then it must be in writing, signed and witnessed, and include that statement. The current code of practice, and it's only a draft code of practice for Northern Ireland, doesn't have that in it, and I imagine that will need to be amended and added in, because without that, I think the validity of ADRTs when it comes to refusing life-sustaining treatment will be massively questioned without those safeguards. When you have it, it should be shared with everyone relevant. So this is just another example. I wish to refuse the following specific treatment. So I wish to refuse ventilation, breathing using machine, even if my life is at risk as a result. In these circumstances, if my motor neuron disease progresses, so I can no longer breathe by myself. So that is very clear about the treatment that you want not to receive and under what circumstance, and it has to be that black and white. If there is no ADRT, a question that often comes up is who can make the decision? Do we have legal proxies for healthcare decisions? And it wouldn't be uncommon that we hear, oh, I've got power of attorney, I have power of attorney. But what does that actually mean? So lasting power of health and welfare attorney exists in England and Wales, so people can make decisions based on finances and health on behalf of their named person. Scotland have a similar system. The welfare power of attorney can do that in Scotland. But in Northern Ireland, there are no such powers at present. But the new Mental Capacity Act will introduce this here for the first time. We're going to have lasting power of attorney for health. Up until then, if someone says, I have power of attorney, this is what they're talking about. Property and finance, and that's what we've had in Northern Ireland up until now. So family members could have power of attorney, but it's purely to look after money. It's not to look after health decisions yet. In terms of this, just a quick run through what power of attorney for property and financial affairs in Northern Ireland looks like. You can set limits. So you might decide that someone can manage your money for you, manage your finances, but they can't sell your house. You can cancel or amend that at any time while you still have capacity. The power of attorney stops when you lose capacity to manage your affairs. And that's where an enduring power of attorney comes in. So if you have an enduring power of attorney, that can continue after you lose capacity. That person can continue to manage your finances for you, but it must be registered with the High Court for it to become an enduring power of attorney. When it is registered, the individual that it's been registered for is given a notification as well that has been done. So that's the legal bit over. Just back to advanced care planning and really what the future has in store in Northern Ireland, because this is a hot topic here at the minute really. So we have our personal and clinical aspects, and all of this will come together to give you an advanced care plan summary. And this is from the Regional Programme Board, this slide. There is going to be a regional advanced care plan summary form coming out. So it's not a legal document, but it will be a summary of all of those important conversations that have happened. It will enable the sharing of the wishes of that individual. It's in addition to other forms, so they might have an ADRT or a DNA CPR as well as this, but this is to communicate all of the important conversations. The idea is that this summary form can be coded into the GP clinical system, and that in time that will generate a key information summary on ECR for all of these patients, which would be really useful. And that's it. Thank you very much.